I'm Dr. Shashwat. I'm an additional professor here in the Department of Neurosurgery at AIIMS. And I want to present a case which we very commonly encounter in India. And because India is probably the TB capital of the world, so this is unfortunate, but this is a situation here that we often encounter very advanced cases of tuberculous spondylitis here, and this is one of those cases. And there is nothing very extraordinary about this case, but I think it will be a good learning exercise for the younger member of audience, for the residents. So this was a lady who presented to us with paraparesis for 3 months, and there was numbness in bilateral lower limbs for 4 months, and she had bowel and bladder incontinence also. And she was discovered to be pregnant at the time she presented to the hospital, and because of the complex nature of the treatment that we had planned for her, we advised her to undergo medical termination of pregnancy, and she underwent this MTP at 16 weeks. And at the time of referral to us, she had spastic paraparesis of bilateral lower limb, spastic paraparesis, and there was severe spasticity in bilateral lower limbs and sensory loss with localization below D8 level. And patient was started on modified antitubercular treatment, but she had been on that treatment for past 1.5 months, but she did not show any improvement. So this is the pre-op MRIs. So this is a T2 weighted imaging showing some compression at D4 around mid dorsal spine. There is some kyphosis also evident, along with probably collapse and resorption of one of the vertebrae. So, and this is contrast imaging. As you can see, there is involvement of multiple mid dorsal vertebrae involving D4, D5 and D6 vertebrae with there is a epidural soft tissue component also compressing the thecal sac. And these are the axial images at the same level. A CT scan, mid-sagittal CT is showing a gibbous deformity, and these are the axial images showing involvement of multiple dorsal vertebrae. The lower half of the D4 is involved, and I think the right side of the D7 was also involved. So D4, D5, D6 and D7 vertebrae were involved. So now I would like to stop and invite suggestions from the audience that how should we proceed in this case.
Yeah, let's start with the younger one, right?
So should we actually operate this case, or we can still wait and observe?
Yes, Yatendra, please.
We don't have that imaging because...
Was the trial of AKT given? That time the patient was well preserved. Was any attempt made to find what is the real diagnosis?
We did not get a tissue diagnosis in her case, and I think one of the sputums was positive for AFB.
In today's MDR being so common, and
yes,
nobody is justified in starting a trial of AKT. Gone are those days when you could start trials of AKT. You have to make every attempt to get a histopathology before putting the patient on AKT. So was any such attempt made, and what was the image? Was the imaging? We operate TB-Y. We operate TB-1 if there is neurological deficit which is matching the neural compression. 2, whether there is instability or instability is anticipated that now this TB process has destroyed the pedicles, there is going to, if more than 2 columns are involved and middle column, so his patient is going to. And third, when we don't know what is the diagnosis is under doubt. But in today's, because of the resurgence of XDR and MDR TB, the first attempt must be to get a histopath.
Yeah, actually this patient presented to the gynecologist. And they had, and then she already was on ATT.
Yeah, this is another thing. In extrapleural TB, there is nothing like modified TB treatment.
Yes.
In extrapleural TB, if anybody starts modified TB treatment, that is disaster. In spinal TB, in brain TB or tuberculous meningitis, all these modified regimes are okay for pleural tuberculosis. That is what I feel like. There might be people with different experiences. But that is
modified was in the sense that we already were giving 4 drugs, but we also added linezolid on the advice of our infectious diseases.
Yeah. So but still it was without histopath.
Yes. We did not have, we had only AFB, that is one sputum culture, sputum AFB was positive, and
on the basis of that.
On the basis of that.
The bony destruction, whether this bony destruction was there before or whether it came in this 1.5 months.
Serial imaging, unfortunately, we don't have. So this was the imaging that we got.
Now let somebody from behind answer what they
Yeah,
want
yeah.
to do.
Yatendra from behind is waiting.
Give him.
I would like to approach this patient from posterolateral approach. We will do multi-level corpectomies and put an expandable cage, and 2 level above and below the pathology we will do the with pedicle screw and rods.
Okay, so that means that this was involving like right from the lower half of D4 to probably the left side of D7.
D4, 5,
The
6,
D
4, 5,
D7, yes, D7 right side of the D7 was involved. Right half of the hemivertebra, like not hemivertebra, right half of the D7 was involved by the. I will just show you. So yes, so this is yes. So we can see this. So this is the D7 vertebra, and the right half is involved.
Your CT scan, the CT scan guarantee that yellow line has to be tilted along.
Yes, but
this is not a correct image.
yeah, actually this is from our own packs, but we have the radiologists have that packs where you can adjust the tilt
so
lines.
The students must learn that when
Yes.
they have to incline and tilt that yellow line along
Yes.
this, then only you will know what is the extent of the
Exactly.
bony destruction.
It should
Otherwise you will get misguided.
Yes, it should be always parallel to the end plate.
Correct. And you have to tilt it as you, if suppose there's a kyphotic deformity, otherwise you are going to get a wrong impression, bone is strong
Yes.
over here, or you can make a wrong diagnosis.
Yes. So there was actually reading this CT is also a big problem unless you can adjust the tilt lines,
Correct.
because then you have to extrapolate, and then you have to look at all the other visual cues to ascertain which level you are looking at, because these all levels are collapsed and you can see a gibbous here. So any other thoughts on this, like somebody wants to just conserve this patient and watch for maybe do a core biopsy or look for MDR?
What is no suggestions?
Yeah, no suggestion.
Why?
So why no suggestion? That's
So
no
as-
question I can ask. Yeah, please.
Yes,
Why
yes,
no
sir,
suggestion?
Professor.
What do you think?
Yes,
Yeah, come on, one.
yes. I want to.
not have big experience in tuberculosis cases, but I think it's optimal decision two-stage surgery, from posterior fixation and then go to anterior decompression and using mesh.
Okay, so you are suggesting that first we do some kind of laminectomy, and
Yeah,
at second stage we go like transthoracic?
Yeah,
Transthoracic.
because
okay.
if you go first stage here and try make anterior decompression, it's spinal cord compression
Yeah,
from
yeah,
posterior side.
okay.
With no free space
Okay.
to keep a little movement for spinal cord,
Yes.
and
Okay.
it can increase dramatically neurological symptoms. That's why I prefer do posterior decompression, stabilization, and then second stage anterior decompression and vertebral body replacement for maybe 2 vertebral body.
So
And in our country we use before surgery chemotherapy for tuberculosis
okay. Yeah.
always. Always.
Yes, she already was on anti-tubercular treatment, but she failed to improve on that. So that is one of the indications for surgery, and there is an element of progressive deformity because of the resorption of 3 vertebrae.
You agree with this concept of doing laminectomy? Is laminectomy necessary?
No, I would slightly disagree, because that would actually worsen the
What's the
instability.
problem?
Worsen the instability, and the problem with doing 2 stages is that most of these patients are quite malnourished, and like if you do a laminectomy, you are already kind of destabilizing them, then you have to go in early for the second stage, that is to place an anterior construct to bolster the anterior column of the spine. So I don't think the patient will allow 2 surgeries, and with the kind of undernourishment that they have. So what we planned was actually to do everything from posterior, and since we can see, as Professor Patkar has told, that there is already.
Shashwat, just a second.
Yes, sir.
So I think this is sort of a typical scenario that we see in almost every OPD. You will have a typical patient like this, and this is relatively early presentation. So here are 3 issues. One, what is the diagnosis? And second issue is, say, if you think it's tuberculosis, whether to start ATT, whether to start with standard drugs, or bit something modified, or you want biopsy to confirm it.
Okay, sir.
And third thing is whether you want to intervene or not, or if at all you plan to intervene, when. So the first thing, diagnosis. As far as the diagnosis is concerned, to me it looks like tuberculosis because of, look at the radiology, the MR, the T2 images, hypo, a lot of collections all around the vertebrae, and the typical involving the anterior, middle, and the posterior column. This is very typical of tuberculosis or infectious disease. If it is a malignant, it's unlikely to involve all the three columns simultaneously. So that's one. So as far as the diagnosis is concerned, in our setting, I will not have any doubt whether this is tuberculosis, number one. And number two, starting ATT. So we always start ATT even if I have a slightest doubt. So reason for that is, again, the radiological pictures are very typical. And second thing, we always start with standard 4 or 5 drugs, including streptomycin. We don't start with some modified regime or something until unless you have the chemosensitivity report available with you. So even if it is resistant to 1 or 2 drugs or 3 drugs also, that drug testing is done individually for that particular drug. But same 3 drugs to which it is resistant, if you start simultaneously, it's well known that it responds. So all these first 5 drugs, ANH, rifampicin, pyrazinamide, ethambutol, and streptomycin, these are very well tolerated, very safe drugs, and all other second line drugs are absolutely, they are very toxic, and very rarely patients will be able to take those drugs in a dose that is recommended. So you always start with first line drugs, 5 drugs. So that is the issue number 2. The third issue is whether to operate or not. This patient, when came to you, is already 0 power, right? So you don't want to wait, irrespective of whatever. You want to intervene, you want to decompress, and thereafter you want to align and fix. These are the 3 issues. Suppose this patient was, say, grade 3 or 4, then we would have waited. The reason for that is, if you go at this stage, whatever vertebra you are seeing, the proximal one, you say like is 1/3 destroyed, 2/3 still okay. But when you operate, you will find that that's just like butter. That will not take any screw, that will not take any cage. If you put in a cage, it's going to have a lot of subsidence. So that's the problem. But anyway, in this case, power is 0, so you can't wait. You have to go ahead. So in this case, I think it would be reasonable to go posterior, resect all those vertebrae which are involved, put in a long cage, big size cage, filled with bone, and maybe 3 level above and 3 level below fixation should be reasonable. I mean, in a single stage, this is doable in this particular area.
Yes. So regarding
I always give it. Giving streptomycin sort of, ensures that patient is taking some anti-tubercular. If you give tablets, they come in different combinations, different doses, but streptomycin is almost 1 gram or 0.75 gram, that's always standard. So this makes sure that patient is taking some drug.
I agree with you. There is nothing better than streptomycin.
I'm sorry, is it possible to see the MRI?
Okay, yes.
Yeah, so we can have the MRI, please.
So the patient is paraplegic?
Yes.
Yes. Since how many days paraplegic?
She has been paraplegic for around 1.5 months.
So my personal opinion is to do posterior approach with bilateral peduncolectomy. First, remove all what I can reach by peduncolectomy by performing a somatectomy as much as I can, and the compression of the vertebral canal, so relieving and decompressing the spinal cord compressed. Then to stabilize 3 levels above, 3 levels before, to perform CAT scan, microbiological, histological examination, to see the patient, to judge the possibility of an improvement or not, and then staged second time, eventually, to reconstruct the body. Because I'm not sure that by using only posterior approach is possible to reconstruct the body. Moreover, we should need something telescopic, because we have to distract, not possible in case of disease, because metal, titanium is contraindicated. Otherwise, natural bone is indicated in infection disease, and that's my personal opinion.
I think this myth has been
Yeah,
destroyed in
yes.
India long ago.
Titanium is
Long ago
perfectly
it has
okay.
been destroyed in India. We are putting titanium very easily in most TB patients without any problems. If you'll find in India, most of the patients, they will remove and put a distractable cage from behind and patient is going to do well if this is not drug resistant TB. But my argument is that why not do anterior surgery? I would offer this patient a good decompression is from the front, the disease is in the front, the better clearance is from front. This is at a site which is easily accessible. This is D5-6, this is the most ideal site to do anterior surgery. And you can put double rods from the front with cage, with distractable cage. But the most important thing will be the good CT scan to study. There is the Hounsfield value of the bone on the CT scan is very informative about the capacity and the involvement of the vertebra and how much screws it is going to hold.
Yeah,
So
that's true. So yeah, definitely. So we have various approaches. One anterior approach, but I mean nowadays like
So my
posterior approach has become popular because orthopedic surgeons don't want to do anterior surgery.
yeah, even neurosurgeons.
That is
don't want
why
to do
these orthopedic surgeons they brought in. And previously what happened, neurosurgeons also were predominantly doing 6-year courses and coming, they didn't want to do anterior surgery.
Yeah.
Now the people like him coming from KM hospital like me, we believe what is thoracotomy. There is a myth has to be destroyed.
Yeah, but over the period of time, the education is changing drastically, and now hardly people get to do those kind of things. So I mean, now it is depend what is popular, what is going on, and that's what you are being
But-
trained for,
yeah,
right?
but
So anterior is definitely one approach, and I mean, if you can do it, well, good.
literature is actually unanimous that the morbidity of
Will
transthoracic
you answer,
surgery is
Professor? Does everybody know? Are you reluctant to put titanium?
no,
cage in the-
not at all, not at all.
Titanium
Because
is not a problem.
this is unless it is a bacterial spondylitis, like
In infective spondylitis, non-TB, yes. If
Yes, it is.
Pyogenic, we are very reluctant to put metal. But in tuberculosis,
Yeah, it's a routine practice, day in day out is being done. No confusion, right?
yes.
Perfect. So
So
what
there
you
is
did-
no contraindication
Yeah,
for
what you did?
titanium implants in mycobacterial infection spondylitis. These
See,
are chronic.
One last thing, like
yes.
why we, at least I don't prefer to go transthoracic in case of tuberculosis, because suppose there is bacteria, right? Everything is going to go into the pleural cavities. We don't want. Adhesive tubercular pleuritis is. Pardon? Yeah, that's what. So that is the reason we don't want to breach pleura. Pleura is in the pleural cavity that the dura does for the brain. So you don't want to breach that thing. That is the reason you want to go from the back.
so what you did?
Okay, my philosophy was that I will because this is a mid-thoracic region, so I will go only posterior, and I will sacrifice roots on one side to put a cage and to do anterior decompression. So that is what I did. So
Standard practice at AIIMS we see.
this is, so we did D2, 3 and 7, 8, 9 fixation on one side, and on the right, on the side where the pedicle was spared, that is the left side. So the left side of D7 pedicle was fixed, and on right side we did D2, 3 and 8, 9, and then we also did a cage placement. So we sacrificed the root on the right side because there the epidural collection was significantly larger, and because it was all soft tissue and granulation, so there was no difficulty in doing corpectomy because it was all soft tissue. So that is the CT scan. So
This
we
is an
got
expandable cage or
no,
mesh?
this is a simple mesh cage.
Non-expandable.
Non-expandable. I distracted it a little bit and then put a mesh cage, and this is resting on the superior end plate of D4 and the inferior end plate of D6. So normally for corpectomies we like to remove the disc and go till the healthy end plate, but in tuberculosis the school of thought is that as soon as you see a relatively robust end plate, then you can put a cage. And usually in our experience, because these are infective processes, there is a lot of granulation tissue, lot of inflammatory substances in the milieu, so they lead to robust bony fusion, and this is what I have seen with tuberculosis, and it is relatively early as compared to even in trauma, as compared to corpectomies and cage fusions done in trauma. So any other comments or?
There is any improvement?
No, this I operated just 1 week before, so patient is same as
Yeah,
pre-op,
if it
but
is
she hasn't worsened. That is the
tubercular patient will always improve, even if they have zero power for
Yes.
2, 3, 4 months. We have seen they will improve. They come walking maybe 6 months
Yeah,
later.
I mean that is one of the most surprising
Gratifying
thing and
things
very gratifying
about
thing.
Tubercular sensitivity test or something has come?
No, we have sent it. We have sent all the tissues and.
But it is that CBNR test, rifampicin
Yes.
sensitivity.
Yes, yes.
It is there.
Histopathology, what did you get?
We haven't. This was
1 week
4
back.
5 days back.
So it will take 3-4 days.
24 hours, 48 hours, you know, 5 days.
Yeah, so it's
There is a workload for everything.
So-
So
it's
the
not so
signa-
fast as
The
in Pune.
signature that it is tuberculosis demonstration of mycobacteria on the slide.
Yes.
The other signature is presence of cell, caseation surrounded by
Langer.
epithelial Langer. But if you see mycobacteria, many times we get on table also, mycobacteria seen, finished. So it is important, but I can understand AIIMS there's such a lot of patient load. But one question and one kind of comment I will tell, see this was the lesion was at D5. So this patient was breathing on the first 4 intercostal nerves and on the diaphragm. You have to be very, and especially she had also miliary tubercles in her lungs. This kind of patient can have a lot of problems in the post-operative, early post-operative period. So when you operate these patients, you know, it's not just your surgery, but also the, you know, working hard on physiotherapy and the lungs, because she's breathing only on 4 intercostal nerves.
Yeah, perfect.
So
Very
was,
nice, yeah.
Was
Yes.
there pus or any collection there?
No, actually, this was already. She had been on ATT for last 1.5 months. So mostly there was granulation and fibrosis.
Yeah, granulation fibrosis is indirectly.
Yeah. And
What
there was
gene
no,
expert.
Huh?
Gene expert.
No, we did
No.
not send gene
No,
expert.
we generally send all the things. I mean, I don't know, but it takes time. It takes weeks time for everything to come.
Gene
But
expert is
there
relatively
may
rapid.
be AFB negative and all inconclusive reports also. The MRI finding is validated for starting
Yes,
ATT
yes.
many a times.
Yes.
Yeah, correct.
Yeah,
correct.
rightly said.
No,
And
she was already
invariably
sputum
you
positive. Yes.
you will not find bacteria in these cases. Invariably, there won't be any bacteria. Only thing is telltale signs suggestive of chronic inflammation, which is consistent with tuberculosis.
So very nice, Shashwat. Thank you very much for very nice case. Meanwhile, I invite.
Did you choose purposefully to go posteriorly, or you didn't had any choice for anterior approach?
No, I personally did not prefer an anterior because everything could be done posteriorly. It is like we could put
In such
anterior column
cases-
reconstruction was also possible, and
In such cases, do you consider for pulmonary function test before going anteriorly if you are planning for anterior approach?
pulmonary function, of course, like we would like to see,
Yeah,
but in
it's correct what you are asking. Most
Because you are
important
going for
pulmonary function.
breath holding
and we are
time
going,
is
and single lung ventilation sometimes the patient may not tolerate.
yes.
So we might have to
The
cancel the
anesthetist would
surgery and again-
hardly would do a breath holding time
Yes,
and
that is the most important pulmonary function test. Single breath holding count. And
Thank you.
single lung anesthesia is not required for most.
So if at all it is, I mean, affected, what will do?
You can keep tidal volume a bit low. Single lung ventilation is never required. With both lungs functioning, you can easily retract and work. If you have to work only at the vertebra, because there's a posterior-most part of this.
And intermittently shout at the anesthesia.
Yeah, not.
We have seen the evolution in our department. Initially, there a lot of cases were done through thoracotomy in trauma center also anteriorly. There were a lot of morbidity and some mortalities, sudden deaths also. So nowadays, I think for many years we haven't seen through thoracotomy. We always go from posterior.
Yeah. So I mean, this is a trend, but we don't shout at our anesthesiologist, right?
we have very cordial relationship.
Yeah,
with
very
our
cordial
anesthetists.
relationship. None of us has wife as anesthesiologist, I think, right? Horrible, yeah. I said us.
Why,
You know,
later on you ask him in the evening why surgeons should not marry anesthetists and why many surgeons end up marrying anesthetists.
yeah, I mean, yeah, we can have a talk. So another important thing is consent. I mean, you should mention everything. This is like, these are a complex case, critical case. You cannot just go in. To document everything in this medical legal era is one of the paramount important. Isn't it, Dr. Shashwat?
Yes.
Yeah, perfect. So meanwhile, we can go to OT4.